Thanks everyone for joining. We're in the middle of your academic half day, so get a little glucose to get you energized. So this is part of a QI project doing with Dr. Agarwal, one of our endocrinologists, primarily works at Morningside, but also at West. And Sananda, one of our chiefs, Heba, Kirthana, another PGY2, and myself. This QR code is to a pre-survey. Some of you may have done this when during the boot camp from Dr. Singh. We have about low 20 responses. If you want to do that at the beginning of this, it'll take 3 minutes. There'll also be a post-survey. So if you haven't filled it out, please take a look and do so we can have a good balance of pre and post-survey results. So with that, we're going to get into a practical approach to management of inpatient hyperglycemia in non-critically ill patients. So some of our learning objectives for today, we're going to look at glycemic targets in hospitalized patients, some anti-hyperglycemic agents in hospitalized patients, blood glucose monitoring and prevention of hypoglycemia, consultation to diabetes care providers or endocrine, and some discharge recommendations as well. There we go. So a little background, inpatient hyperglycemia affects both patients with diabetes and with no history of diabetes. Both hyperglycemia and hypoglycemia are associated with adverse outcomes, including death, and therefore inpatient goals should include the prevention of both hyperglycemia and hypoglycemia. The hospital should promote the shortest safe hospital stay and provide an effective transition out of the hospital that prevents acute complications and, of course, readmission. I like to make a note that for patients without diabetes, hyperglycemia may, in fact, give us a worse outcome. Studies have shown that newly diagnosed hyperglycemia leads to longer time of hospitalizations, higher admission rates to ICUs, and higher rates of discharge to nursing home care. And as we can see on the next slide, the study that I just referenced was called Hyperglycemia, an independent marker of in-hospital mortality in patients with underdiagnosed diabetes. This was a retrospective study of about 2,000 patients in 2002 with what they called with hyperglycemia, but particularly focused on new hyperglycemia. We know that definitions for diabetes include HbA1c greater than 6.5, fasting glucose greater than 126, and a random glucose over 200, along with our glucose tolerance test criteria. So in this group of patients, about 12% of the 2,000 were considered new hyperglycemia or never having been diagnosed with diabetes in the past. And 29% of these patients went to the ICU. You could see the demographics for those of known diabetes and normal glycemia. And what it found was that these patients experiencing new hyperglycemia actually had a significantly higher inpatient mortality, both in the ICU and non-ICU. So these patients with newly diagnosed hyperglycemia also had lower functional outcomes than patients with a known history of diabetes as well, or the normal glycemia. And for those of you who've been on the floors in the ICU, you know and experience uncontrolled hyperglycemia as a main driver in hospital mortality and prolonged stays with our COVID patients. So it's important to know that hyperglycemia is important to be treated, again, both in known diabetics and those without diabetes. So just a brief overview. What we've shown here is that diabetes has been increasingly encountered in hospital inpatients and the primary care setting, regardless of the reason for admission or comorbidities present. During 1999 and 2016, the age-adjusted prevalence of total diabetes significantly increased amongst adults 18 years of older. You can see that at the turn of the century, it was about 9.5%. 2013 and 2016, it was 12%, and it's rising even further. In fact, the CDC in the around 2020, the 2018 Census Bureau data showed that about 34 million people of all ages in the U.S., about 10.5% of the U.S. population had diabetes. So it's becoming a more significant part of healthcare. And diabetes affects all our organ systems, as we know, the heart, the kidneys, many more. So some basic definitions we have here. The American Diabetes Association Standards of Medical Care in Diabetes targets a glucose range inpatient of about 140 to 180 for inpatient, also including the ICU. And I'll get to the nice sugar study in a second. This glucose range, we like to look at a pre-meal or fasting blood glucose, hopefully less than 140, and a random blood glucose less than 180. And depending on the patient population, there could be a higher or lower target. The higher target being less than 200. These are for patients with terminal illness, limited life expectancy, or high risk for hypoglycemia. And the lower target is about 100 to 140. And these are patients who are able to achieve and maintain glycemic control without any hypoglycemia. Now, stress hyperglycemia is an entity encountered in non-diabetic patients, to be distinguished from hyperglycemia in a patient who had diabetes. Essentially, they also have normal HbA1c levels as well. You can also do a peri-admission A1C to help distinguish between a patient who doesn't have diabetes but currently has stress hyperglycemia, or a patient who has hyperglycemia in the setting of previously undiagnosed diabetes. As we know, our HbA1c comes in line with our red blood cells and kind of give us a good 3-month average of our sugar levels based on the life of the red blood cell being about 90 days. And in clinic, it's useful to say that patients who have been saying their sugars have been good, you get to test them with an HbA1c, that'll prove otherwise. And lastly, we have hypoglycemia, and this is defined as blood glucose less than 70. When we get to severe hypoglycemia, blood glucose is 54 or lower, and characterized by altered mental status or physical status requiring assistance. And all these definitions apply to patients treated in the inpatient setting with anti-diabetic medications, whether oral or injectable, whether insulin or non-insulin agents, hypoglycemia. And different values may define hypoglycemia and severe hypoglycemia in different situations. These are thresholds chosen for hospital management to help standardize our care. A normal patient could have a glucose less than 70 and not truly be hypoglycemic. A lot of our patients have good hypoglycemic awareness when they know their sugar may be low, but they feel okay, or they know something's going up with their sugar and they need some treatment immediately. But if we're actively managing blood glucose, any blood glucose less than 70 should be treated as a low, and as the point in time measurement may be catching the glucose maybe on a downward trajectory, given use of anti-diabetic medications. And it's really important to rigorously avoid hypoglycemia. Hypoglycemia has been shown to cause more complications in, not necessarily versus hyperglycemia, but in general, hypoglycemia is more dangerous than hyperglycemia. And alluding to this nice sugar study, this was the intensive versus conventional glucose control in critically ill patients. Essentially, this was a multi-center parallel group randomized controlled study, non-blinded, of 6,000 patients with an intention to treat them for the reason for admission and to treat their glucose in 2 separate ranges. They had the intensive glucose control group, which was a goal of 81 to 108, and a conventional glucose control group, which was a goal of less than 180. Again, this was in critically ill ICU patients. And the primary outcome was 90-day mortality. And you can see, based on this curve, that the intensive pathway, or the intensive glucose control group, was significantly higher, about 2.6% more greater mortality than the conventional glucose control. So this 140 to 180 range really applies nicely across both non-critically ill, but also critically ill patients. So now we'll get into some of our anti-hyperglycemic agents, particularly insulin, which is a lot of what we deal with in the hospital setting. There are patients who come in who are diabetics, who are on orals, who are on a combination of oral and insulin, or just insulin alone. But insulin is very easily titratable, as we'll get into in this lecture, compared to some of the oral medications that patients have been on. So insulin therapy should be initiated for treatment of hyperglycemia starting at a threshold of 180. We're known diabetics as well. And there are largely 2 types of insulin that we deal with mostly. This will be the long-acting, our basal insulin, and our short-acting, which is our bolus insulin. First, discussing the long-acting, you can see by this red flat line right here, this is our glargine, Basaglar, Detamir. Basically, this is insulin that it mimics our basal rate of insulin, which I'll get into on the next slide. It has no peak of action. As you can see, it's a flat line. It starts working in the first 2 to 4 hours, and it has an effective duration of about 20 to 24 hours. And this is why long-acting insulin is given every 24 hours to keep a low constant basal rate of insulin in our body. And typically we like to do that at bedtime because while you're sleeping for the given 6 to 8 hours that an adult should have, we're not actively eating, we're kind of in a fasting state. And this low, slow insulin will prevent hyperglycemia, but may also prevent us from going into hypoglycemia, given that its relative level is a bit lower compared to our quicker acting insulins. And into that, we have our short-acting insulin, which is, you probably know it in the hospital. Mainly we use Lispro, but there's also Aspart. And this is represented by our steep black curve right here. This insulin has a quick onset, about 5 to 15 minutes, has a peak action about 30 to 90 minutes, and lasts about 4 to 6 hours. You'll see we like using this as our sliding scale, insulin as well. Can be scheduled preprandial as well. And you'll see that's why we give patients insulin every 4 to 6 hours NPO, is because it mimics the effective duration of this insulin. But we'll get into that a little bit later as well. So this is a slide borrowed from the endocrinology department at the University of Michigan. And what it shows is our normal insulin profile, which is up here, and our normal glucose profile up here. And this is in a normal patient without diabetes eating 3 meals a day. And you can see that there's always a low level of circulating basal insulin and basal glucose, which is represented by these orange bars. This insulin, as I said, is our basal insulin, and it matches the glucose. Because of this, you can see, sorry about this, lost my place. Great. This circulating basal insulin really helps to suppress glucose and ketone production in our periods of fasting. And the basal glucose is there, so our glucose doesn't fall to 0 while we are not fasting, or while we are fasting. As you know, even though we may not be moving or in a rest position, our body uses glucose in many other places, the little muscles that keep us upright sitting in this chair so we don't fall asleep during this lecture, to a lot of different other things. So you'll see that the glucose levels rise when a person eats a meal, and the insulin rises as well. And this rise in insulin above the basal level is referred to as our nutritional insulin because it matches our nutritional intake. Basically, these serve to balance each other out. And in diabetes, we kind of get a mismatch of this, type 1 diabetes, where we cannot, where someone will not be able to produce their own insulin or very little of it due to destruction of the beta cells, and type 2, where we meet insulin resistance, where the body doesn't respond to insulin as it would in a non-diabetic. Now, a normal human, the person who does not have diabetes, eats 3 meals a day, secretes about a total of 25 to 30 units of insulin per day. Half of this is secreted as basal, and about half is secreted as nutritional insulin. So understanding this physiology, this natural physiology in a non-diabetic patient, helps to guide us in creating our total daily dose of insulin, where typically we like to use half bolus and half basal. Other notes, in acute illness, total daily insulin requirement may increase, even though the patient may not be eating, possibly as a response to stress hyperglycemia. But this physiological insulin will revert back to baseline as recovery from this acute illness takes place. So the bottom line from this slide is, in a normal person without diabetes, there's basal insulin that is relatively constant across 24 hours a day, and basal glucose as well. Insulin needs to go up with meals as glucose rises due to digestion of food, and understand this physiology helps us create total daily dosing for our inpatients. Now, this dosing can be done in 3 simple steps. Oops. So you may remember this table when Dr. Singh first gave her lecture in intern boot camp. And it's very good for guiding, kind of creating an initial total daily dose. When you have a patient you just admitted from the ED, you know they're diabetic or they're having hyperglycemia, and you don't know if they're just stress hyperglycemia or they're undiagnosed diabetes. You want to give them some insulin. So just this estimate is just what it says. It's an estimate. This formula and table helps to guide us. And it's important to know we like to start at 0.5 units per kilogram per day as a baseline. Then different factors of the patient, such as those listed on the left side, will help guide us to subtract or add to that base. It's important to note that this N value, or the 0.5 or whatever we add up to, in type 2 diabetics sometimes is greater than 1, which may be startling, but It is true. If a patient has an established prior regimen that shows he or she is taking more than 1 unit per kilogram per day, that's fine. But again, you want to avoid hypoglycemia in the inpatient setting. So it's good to base your calculations off those patients' regimens if you have it. But you may also need to hold back a little bit and kind of give them some time in the hospital to see how they're doing in an inpatient setting. So going through these, we look at age. Age, we take away 0.1 units. Basically, in elderly patients, there is some amount of insulin resistance. However, they also have lower circulating glucagon, and overall, they're just a higher propensity risk to hypoglycemia. So we like to subtract 0.1. We subtract 0.1 in renal insufficiency. We know the kidney plays a very pivotal role in the clearance and degradation of circulating insulin, and it's also a site of insulin action. If the kidney's not functioning, you give someone extra insulin, you can get insulin stacking, leading to more insulin in the bloodstream and possible risk for hypoglycemia. Same with cirrhosis. The liver also a place where insulin is broken down. If you have cirrhosis or sufficiency of the liver processes, the rate of insulin is going to be degraded. Again, you get hyperinsulinemia and lead to higher hypoglycemia. You kind of see a pattern here. We're trying to avoid hypoglycemia. Same pancreatic deficiency. Now, if a patient has a HbA1c greater than 10%, really representative of uncontrolled diabetics, you want to add 0.1 units. And also other signs of insulin resistance, which include increase in weight or recent weight gain, central obesity, infection, inflammation or inflammatory disorder, exogenous steroids, or central obesity itself. You can consider higher requirements. This is why a lot of our diabetics, in most situations, can have a lot of these things, and that's why their total daily dose could be greater than 1. So it's important to know that those with heavy insulin resistance could receive up to 0.7 to 0.8 or even up to 1 units per day inpatient. And another good takeaway from this slide in particular is when in doubt, it's always best to err on the side of a lower total daily dose. Much safer and easier to start with too little insulin and titrate up to achieve control than to start with too much insulin and have to treat hypoglycemia and then titrate down. Also, if anyone has any questions at any time, please feel free. Some other notes in dosing calculations. When you have a patient who's NPO, or you're uncertain about how much food they're taking in or liquid they're taking in, you want to order only basal insulin as a scheduled order, or 24-hour insulin, and then sliding scale on the side in case they do get hyperglycemic. Patients at NPO are certainly at risk for getting hypoglycemic. So having this low basal insulin is great, but we don't need to give scheduled prandial insulin. And as I mentioned before, we like to give this sometimes every 4 to 6 hours, maybe usually 6 hours in terms of the sliding scale and finger sticks, as our short-acting insulin lasts for about 4 to 6 hours. But if patients are eating and otherwise getting nutrition, you can order both a basal and bolus insulin as scheduled orders. Of course, it's always good to have sliding scale on the side. And but there's some caution you want to take with prandial insulin. It's an ideal guideline to begin it on admission. However, you don't want to risk hypoglycemia. So you can wait a day or two just to kind of see patients' insulin patterns before initiating. I'm not sure how many people know this, but in Epic, there is a glucose tab. It's a great tab. I suggest using it. And you can spread it out over 8 hours, 24 hours. It shows all the finger sticks, the serum glucoses, and it also shows what insulin is being given at what time corresponding. And I have some examples later down that I'll show you. The good thing also about our Epic order set is when you go to order insulin, which you go under diabetic agents, what automatically pops up is our hypoglycemic protocol. This includes the order for hypoglycemic protocol, which includes notifying the nurse of certain levels of glucose and what to do with certain levels of glucose. We know a lot of our nurses will give juice. However, it does automatically trigger glucagon, whether oral gel or IV, to be given on certain levels of insulin. So very helpful, helps us avoid hypoglycemia in the hospital setting. So step 2 is to apply our basal bolus concept. As we discussed previously, we know that in a normal non-diabetic human, about half our insulin is bolus and half of it is mealtime nutritional insulin. So we apply that same concept to the insulin we give to our patients here. We like 50-50. You can give or take some in terms of basal and bolus, really depending, again, looking at their curves throughout their admission and titrating as so. So you want to give half basal, you want to give half bolus, and divide that into 3 for each of the meal times if they're not MPO. And you also have the correctional insulin on the side in case you need coverage. And step 3 is titrating that. So you have a starting total daily dose, you see some results, now what to do next. So long-acting insulin, our basal insulin, you should increase this only based on fasting glucose. Again, in the hospital setting, we typically give this at night. So their fasting is going to be that 5 to 6 a.m. glucose read. Typically, you don't want to see a decrease of about 50 when compared to bedtime. However, if you consistently see high morning insulin, especially compared to finger sticks compared to bedtime finger sticks, you certainly want to increase that and keep more insulin in the body throughout the day and in our fasting state overnight. And short acting, again, we want to be careful about increasing short acting insulin. But if you see that the sliding scale or correctional insulin is given consistently almost every time there's a read and at high doses, you want to increase the short acting to avoid that extra correctional insulin being given. And if the goal is not met, you can recalculate the total daily dose, adjust the sliding scale accordingly, and essentially go back through these 3 steps. Again, you have all the tools of Epic at your disposal. So certainly don't be afraid to use the resources that you have there. All right. So next we'll get into some practice cases. This one we kind of working together, and feel free to shout out whenever we go through it. So we have a 60-year-old male, type 2 diabetes. He's admitted for pneumonia. His A1C is 7.4%. About a week before he came into the hospital, and his home regimen consists of only oral hypoglycemic agents. He weighs about 84 kilograms and is currently on a carb-controlled diet. What steps would you take? You don't necessarily have to give me the exact values, but what steps would you take in creating a regimen for this patient?
So anyone want to say if you think maybe you would continue oral hypoglycemics in this patient? Would you try and switch them to an insulin regimen, or what would your thinking be?
Yes, switch to insulin regimen. So we'll calculate how many units a day divided by 2, by half. 50% of that would be basal, and then the other one divided by 3 pre-meal, and the insulin sliding scale in case, and the hypoglycemic.
Exactly. And I know we went over this, but what would be our target range for finger sticks on the floors?
140 to 180.
Correct. Yeah, so all that was correct. Pretty simple. We didn't get into any specifics in this case, but what we do is we'll hold all oral hypoglycemic agents and start with our insulin. We'll get a scheduled basal and bolus. Again, it's no need to rush into the the bolus right away. But if we have a known relatively controlled diabetic, should be okay. We calculate our total daily dose. In this case, 84 kilograms would be 42. We have 21 basal, 21 bolus, so 777 at meals. He had no other risk factors, so we did 0.5. Sorry, I got ahead of myself. And then we'll add our sliding scale insulin. And yes, like we said, we want to target 140 to 180, preferably less than 140 for pre-meal and less than 180 for random. All right, so now we'll get into some questions. So again, feel free to shout out. So what would be the total daily dose of insulin for a 76-year-old female with type 2 diabetes, weight of 65, and normal renal function?
So if you guys want to take a minute maybe to calculate it, and you can post on the chat like A, B, C, D, and what you think this patient's total daily dose of insulin should be. And I'll give you a minute or so to add it up.
You can also say in the chat if you'd like as well.
Yeah, so I see Max unanimous A, so Sam Cheng started off and everyone's saying option A.
Excellent. So great job to everyone in the chat. The correct answer is A. Again, we start our 0.5. The only kind of, I guess, adverse thing we would consider in estimating our total daily dose is that she's 76 years old. So we would subtract 0.1 units. And so we would 0.4 times 65 is about 25 units per day. And then we would do our division from there. And we'll do one more. What would be the total daily dose of insulin in a 6-year-old male, type 2 diabetes, weight of 100 kilograms, admitted for cellulitis? He has central adiposity, central obesity, and acanthosis nigricans, which many of you may remember from our step days is the darkening of the skin, preferably in the folds or the neck area. And his fasting glucose on emission is 180. Again, feel free to answer in the chat or if someone wants to shout it out.
Debbie was first here on the chat. I'm picking option D, 60 units a day.
Okay, so we got a lot of D's. So the correct answer we consider is C. So we chose this. It could even be up to 80 units per day. And the reason for this is we have a patient who's type 2 diabetes. We know that. They have obesity. You can add a 0.1 for that. And they have an acute infection, the cellulitis. So you can add another 0.1 for that. That's already at 0.7. And going back, we see that he is severely obese. His A1C is 12%, it's uncontrolled. So at minimum, you'd want to start at 0.7, and it can go even higher to 0.8 or 0.9. All right. So in the practice case, you're starting your shift as a night flow resident. You got a page from the nursing staff. 75-year-old obese female, type 2 diabetes, A1C 7.9, admitted for melanoma. She's scheduled for an endoscopy in the morning, and GI messages you NPO after midnight. Put her on pantoprazole as well. You review her home medications. She takes glargine, which is our long-acting insulin, 80 units at bedtime, and 15 units with meals. Seems like a lot. Again, we don't have her exact weight here. Sorry about that. So in addition to starting the sliding scale every 6 hours while NPO, as we mentioned, what's the most appropriate dose of glargine while she remains NPO?
So you can post again in the chat whether or not you want to hold it, continue it the same way, reduce it from 80 to 25, or reduce it from 80 to 60. So I think maybe a bit more confusion on this one. So some saying A and some saying B. So either hold it and continue it at sliding scale. Salvador saying drop it to 60 units and keep the sliding scale.
Okay. So Salvador has the correct answer here, and I'll explain why. We didn't really go over this, but this is kind of a trick question to see what you guys would think. And it did mean to say D, not C there. So the decision of a patient who's NPO and a type 2 diabetic is really dependent on their level of glycemic control. We typically like to reduce about 20% while NPO for their basal long-acting insulin. For a patient, what we call multiple daily injections, which is a patient on basal insulin at nighttime, but also on prandial insulin as well. Again, MDI, multiple daily injections. But sometimes, depending on the patient, they may need close to a reduction of 50%, especially if they're basal heavy, which often implies they're overtreated with basal insulin to compensate for undertreatment or no treatment for postprandial hyperglycemia. Again, this patient is taking 15 units of scheduled mealtime insulin at home. And taking away food from such a patient like this can certainly give a risk of hypoglycemia, especially if the same basal insulin dose is continued. So in this case, we had a patient who, again, was taking 80 units at bedtime. So we have the sliding scale on. We want to reduce by about 20%. The other answers were more than 20%, or sorry, were more than 50%, or not in the 20 to 50% range. So it was D, not C. You want to decrease to 60 units and use the sliding scale. And again, this patient is, we're basically looking for that overnight before the endoscopy coverage. Hopefully nothing's found in endoscopy and they can resume somewhat of a diet afterwards. And then you can titrate the insulin to the GI racks in terms of the diet. Other things to note, with type 1 diabetics, mealtime and prandial insulin should be discontinued and withheld while NPO, but correctional insulin should not be. Like in this patient, we did continue to their longstanding insulin, but they were type 2 diabetic. And you, as we said before, you want to keep the correctional insulin orders every 6 hours, 4 to 6 hours, rather than mealtime and at bedtime, to ensure that the correctional insulin is doing its job from 4 to 6 hours, and if there's a necessity for more as well. So on to our last practice case for the day before we get into some discharge recommendations. So you're on the floors and the AC screen calls you and says, hey, this patient, they had DKA, the gap is closed. They were on insulin drip for a little while, but we've weaned them off of it. They're coming to the floors. We need you to manage them and give them some treatment to bring down their sugars or keep them low. So this patient was a 79-year-old male, history of diabetes, a stroke with residual left side of weakness and nonverbal, baseline ANO2, and hypertension. Initially presented with altered mental status, dysphagia, found to have DKA, sugars were in the 700s, ketones positive, and again, treated as I mentioned previously. At home, he takes insulin Lantus 10 units at bedtime. I'm sorry, that was not his home dose. Currently transferred to you, he's NPO due to the dysphagia. Normally at home he eats. And his current regimen is 10 units at bedtime and insulin sliding scale Q6 hours. Now take a look at his scale, his curve here. This was about 2 days after he closed his gap. So you see what I've circled here are the AM finger sticks, or our fasting finger sticks. Again, he's NPO, but we're going by the bedtime insulin to the morning. We see that's 323, 248, 270. So still relatively high above our range. And you can see the curve in most places is relatively flat throughout the day. Now, what adjustments would you make to his insulin regimen? Again, he's on 10 units Lantus and sliding scale Q6 hours. Would you increase the long acting, continue sliding scale and add short acting, increase the glargine and continue sliding scale alone, continue the glargine, continue ISS and add short acting insulin with sliding scale, or continue glargine and ISS and not make any changes? Sorry, that was a lot. You can take a second to think about it and we'll get into it.
So far, most people are choosing option B, increase the glargine and continue sliding scale alone.
Excellent, great job. So that is the correct answer here. As I mentioned, I kind of gave a hint that throughout the day, his slopes were relatively steady. That means his, while he is NPO, he's not requiring everything when it's checked every Q6 hours. Sometimes you can see in patients that they'll have a nice low morning insulin, but around mealtime when they're checked, they'll have these big spikes. And that's when you want to alter the sliding scale or consider starting a mealtime dose. However, in this NPO patient, we want to start with increase in the glargine. If we go back, you can see at the bottom how much sliding scale he was actually requiring during this time. And he was on 10 units. If we go back over here, you can see we increased to 14. Did have a 300 here. The 600 wasn't real. We were worried, but it wasn't real. And his Lispro decreased. And then when we turned up the insulin to 18, you can see we have a nice good range of sugar measurements here. And during these 2 days, he didn't actually require any short-acting insulin. So now I'll move on to discharge recommendations. So there's a few things you want to do when you're discharging a patient home, especially if they have been on insulin, or more importantly, if they're starting insulin. You want to review the insulin injection technique. If you've been on endocrinology consults, you know that in the offices they have some fake pens, needles, lots of stuff you can practice with. It's very simple. If you can teach it to someone in 2 times, you can definitely learn it in 1 time. We can go over that another day or ask one of the fellows, but it's pretty easy to teach how to give insulin. And then you just do a teach back twice with the patient or whoever's going to be given the insulin to the patient. Next, you want to inquire about barriers to medication regimen adherence. As we know, in the United States, insulin is getting more and more expensive for reasons we cannot say, or whether it's big pharma. I'll stay out of the politics there though. So you want to see if their insurance is covering the insulin you want to prescribe them, whether it's through pens, whether it's through a vial, whether you're giving them oral anti-hyperglycemics as well. So you want to talk to them about their current situation, their insurance situation. You can get social work involved as well. So really, of course, you want to make sure they're not getting hyperglycemic or going into TKHHS at home, but also avoiding hypoglycemia. So if any of you have rotated on endocrinology consults, you know Dr. Agarwal has created some excellent EPIC notes, and at the bottom of each note, there are some of the good discharge recommendations to give. And I've kind of copied them here, altered a little bit. But some of the common prescriptions prior to discharge is you want to reinforce the diabetes. You know, not all our diabetics are doing this. You hope they are, but you want them to check their glucose at least 4 times daily prior to meals and before bedtime. So you want to get them a glucose meter, the test strips. Essentially, you're trying to give them a 90-day supply of all these things I'm talking about. The lancets to poke their fingers, and the alcohol swabs. And a good thing that you may ask them is some of the insurances are now covering our continuous glucose monitors, which you can be seen on the arm, kind of look like a disc or a little USB. Some of them put them on the stomach as well. You can explain the benefits of that, see if the insulin covers that as well, and people can check their sugars on their smartphone, which is pretty great. You've probably seen all the commercials. And then you want to look at the insulin you're going to give. So again, you want to confirm what their insurance coverage, but here are a few options. There's the Basal or long-acting, also known as Lantus, Levemir, or Tresiba. Tresiba is one of the newer ones. It's a little bit more expensive. It's really a long-acting polymer that covers almost, I think, about 26, 28 hours. So if you not exactly at the same time every 24 hours, that's good coverage. And it has been shown to have low risk of hypoglycemia as well, despite it lasting longer. Next is the Admiral Pen Humalog, Novolog. This is our short-acting insulin, our Lispro or Aspar. And then the pen needle is the little tiny insulin needle that you use to actually inject the insulin. So if you're unable to prescribe pens, there's also the needle and syringe technique. They'll give you an insulin vial. You drop your own insulin and inject that as such. Some patients are comfortable with that, some are not. So just a few take-home points. Again, hyperglycemia is very common in our medical and surgical patients, both with and without diabetes. There could be stress hyperglycemia. There could be new hyperglycemia with an undiagnosed diabetic. And all this hyperglycemia can be exacerbated by illness and medications and treatments we give as well. We have to actively manage this because there can be higher rates of infection, mortality, and just overall negative side effects, including those of hypoglycemia. So it's important to find the right insulin regimen to rigorously avoid this hypoglycemia. And again, the big numbers you want to remember, our target blood glucose is 140 to 180. Just remember, nice sugar, 140 to 180 is the range you want to be in. So with that, I know I love using this image, diabetes, let's diabetes this. Here's the link for our post-survey. If you get into the pre-survey, please do this. It's a little bit longer, but helps with our QI project that's ongoing. Our goal is to really help us to kind of manage these patients on our own, not just throw a sliding scale on and leave them by the wayside. And obviously to kind of reduce the burden on endocrinology consults for some hyperglycemia that we probably should be managing on our own. So with that, thank you all for listening. I know it's late in the academic half day. If you have any questions, please feel free to ask. If you complete the survey too, that'd be great. And I'll also send it by email whenever as well.
Thank you so much for that, Max, for a really good and really useful talk on inpatient hyperglycemia. If anyone has any questions, any comments, you can post in the chat or unmute yourself. And obviously, it will be really useful for everyone to use the QR code to finish that survey as well. But if there are no questions or comments,
I have a question, sorry.
Sure.
I was just wondering, like, for example, if I have a diabetic patient that it's like diagnosed during like this hospitalization and I'm gonna discharge him, I have to give like the instructions and everything, but like, I don't know how to give these instructions. What should I do? Like ask my resident, place a consult, or ask who?
Sure. So in case of new diabetics, this actually might be a good time to get a consult, because what we like to do is we could set them up with a primary care physician to manage their diabetes, but we'd like to have the endocrinologist kind of also step in. I mean, while they're inpatient, you're probably sending out their HbA1c, some of the antibodies like the anti-insulin, the GAD65, we have 2 others. But yeah, this would be a good case because based on their A1C and other factors, you want to see if you want to give them oral, you want to give them insulin, how high is their A1C where they might require insulin. If they do need insulin and they don't want to take insulin, there are a lot of factors. So this may be a good time to consult endocrinology, maybe get them on board, and possibly set them up with an appointment. There's a good clinic at Morningside that I'm sure some of you have rotated through. Or you can, if they seem like it's a relatively low A1C, they're fine, they're compliant patients, you can certainly start them on some orals and maybe just get them an appointment outpatient. Really kind of depends on the severity or the kind of the urgency of their diabetes, I guess to say. So plus minus consults, more controlled, more compliant, maybe just an outpatient visit, maybe a patient who's requiring a lot of insulin, inpatient consult. So in the gray area, you can, it's always okay to consult.